So, good afternoon. Well, luckily, quite a lot of what I want to say now actually leads on very nicely from that. It's almost like we did it on purpose. So I want to talk to you about the research we've been doing in Oxford to very specifically think about mechanisms for consent. And this is related to this idea of how you have oversight and control over data and samples in research. And it feeds on very nicely from this discussion around how you actually involve patients more in the research agenda. So it's a funny thing, we're working in a digital health age, and actually there have been some proponents of patient empowerment who have said that actually if patients have a better understanding of what's going on for them and for their healthcare and an oversight and an understanding of that data, that's a huge bonus for the future of healthcare in and of itself. And I don't know how many of you have come across Eric Toppel's book, The Patient Will See You Now, which kind of suggests the direction that medicine might be going in. But he has a strong belief that patient empowerment is really a very important part of the future of medicine, and that the direction we're going is that people are going to be much more engaged and involved in these decisions. I have many questions about how you make sure that's the case for everybody. We won't go into that right now, but that's perhaps a discussion for later. But the idea is that if you're involving patients in how their data are being used and in the decision-making process, that's hopefully going to be a good thing. This is a marked move in terms of biomedical research from the way that it's traditionally been done. It's not that unusual for patients to be enrolled in research. They volunteer to take part and they hear nothing, as we've just been hearing. You won't receive anything back. This isn't about you. This is going to help future generations at best, but you're not going to directly benefit from it. That's kind of been the rhetoric. And actually, as we're blurring the edges between clinic and research, and as we're thinking about actually the data that might be relevant to that individual right now, this becomes more of a discussion about how we actually support decisions across clinical and research, and how we support that data flow as well, so patients can understand what's happening. But keeping track of that data is a challenge, and patients keeping track of what's been stored about them, what's been used, how it's been used, and how it might be relevant for them is going to be a continuing question as the data grows. So I'm going to talk very specifically about consent and potentially how consent can help with this. Informed consent is a significant part of the current research process. You volunteer to take part, and at the beginning of your research experience, you will go through a patient information sheet. You will have described what is going to happen, what the risks and benefits are. You will sign a form. You may never think about it ever again. Increasingly, the research that these people are involved in could span years or decades. And actually, 10 years down the line, their data and samples are being used for something that they have no recollection of, no updates, no information about. And this is, we think, problematic. There are also many issues with the current informed consent process in terms of how it's actually carried out, and we have lots of qualitative and quantitative information that actually often patients don't really know what's happening, and they have higher expectations for the outcome of the research, and they're not really following how it's going to work out. And that's a challenge also. It's partly based on the fact that consent is often seen in some instances as a bit of a legal hurdle to get through. It covers your back, you've gone through everything so that the risks are managed. As I've said, increasingly, there's an innocuous box on the consent form saying, I agree to future use, future research, and this broad brush description can then allow data and samples to be used for all kinds of things. Ethically appropriate, there's been a process, it's absolutely okay for that to be happening, but potentially the participant has no idea. There's also, as has just been touched upon, increasing problems around feeding things back. Do patients want information? How does it influence their current clinical care? All of these questions that are coming up and that we want to help manage. Broad consent is currently the main approach. Sign up and generally agree to things. You have a fairly basic idea of the area of research that might be happening, but in terms of actually knowing what's happening, it's a challenge. I wanted to just give you one example of a study that actually had used broad consent as a starting point for their consent. You may have heard of Genomics England, or the 100,000 Genomes project. This was a project in the UK that intended to help to develop genomics within the clinic in the NHS, to try and sort of set in motion how that would work out. And when you originally signed up to take part in Genomics England, you signed a form agreeing to all sorts of things about what would happen next. You had the risks and benefits explained, you had an idea of what was happening, all exactly as should happen. Quite weighty things that you're agreeing to. You had to receive the pertinent findings back, and you had to agree to things being shared beyond just the initial research team. They also included in this form a section on additional findings, and to begin with, when the project started, you had to agree to everything up front. You had to think about all of these different aspects of genomic sequencing and how they were going to influence you and your family and what they meant all up front. And the experience of the project was that put a lot of patients off. It was overwhelming. They didn't really know what this meant. They didn't really know how to think it through. And it actually stopped people signing up to take part. So fairly quickly within this project, Genomics England then created almost a dynamic element to the consent, so that patients could actually think about this over time, change their mind over time as their circumstances changed. And that was an important way to encourage people to actually be in the project in the first place. So with that, I want to move on to dynamic consent. This is a concept that we've been developing in our team, and it started off with this question of, if I sign up for future research in biobanking in that instance, then does that really count as an informed consent? What we wanted to do was to create a scenario that would actually support patients having a record of their consent decisions that they could come back and review and access and potentially even change over time. And this necessarily broke the consent form down into granular choices, so that actually people had more nuanced control over what they were agreeing to, so that it wasn't just a binary, I'm in or I'm out. It was, I agree with this bit over here, but I'm not sure about this part of the research over here. And it was much more of a conversation, we were hoping, with the researchers. And the way it was supported, in order to make it logistically possible and not too resource intensive, was to do it online, to have a digital record of the consent process that you could then come back and look at. And because you've set up a personal profile for each participant, there's then opportunity to have an ongoing two-way communication channel with patients, such that you can actually send them these updates, send them information on what research is happening and how it's going. That doesn't necessarily have to be research sensitive in response to your question. It could just be, we've recruited enough patients, we've recruited this many, this is how long it's going to take. Some practical information about the research that is of interest and demonstrates how it's moving forward, that just makes it a bit more transparent and a bit more accessible. And because you've got this online approach, you can have different types of information, not just a printed sheet of paper. And this can be tailored to the individual. So you're no longer assuming that everybody needs the same information in order to consent to take part, and actually they can pick and choose what they find useful. So in line with Tanya's talk earlier, the intention is that participants are actually moved into the center of decision making, and it's much more a partnership model. It's not just we're doing research on these people, but it's with them and by them. It enables this ongoing communication, provides this secure record, which is actually as useful for the research team as it is for the participants themselves. And it allows individuals to engage on a much more personalized level, which in the move potentially towards precision and personalized medicine could be really important in the future. In terms of its use specifically in genomics, potentially it gives people a bit more time to think about what they've agreed to in the comfort of their own home, separate from all that's going on within the clinic. And there's actually then opportunity for people to be supported in between face-to-face interactions. We're not suggesting dynamic consent should replace face-to-face, but that actually it's a support mechanism in between. And potentially even in the future, it could address this issue of feedback of results and whether or not people want to have that information accessible to them. It's not just us that think this is an idea, a good idea. We've also talked to quite a few patient groups about whether or not they would be interested, because if patients aren't interested in accessing this information, then there's really little point in us developing it. But we have initial reasonably good feedback. This was a survey that was carried out by Genetic Alliance UK, which is a patient organisation based in the UK that supports different patient groups with different genetic diseases, and their patient population seemed to think that dynamic consent could be a good thing. So we've tried it out in a couple of projects. We're still gathering data on how it works. The first I want to talk to you about is the RUDY study. This is a rare disease network of patients, and the study has really been very patient driven. So if you have questions related to patient engagement and involvement, this is a great example. Even down to the name has been chosen by the patient group that it serves. The color scheme, how the website is laid out, all of these questions have been discussed with patients. And this project gathers data directly from patients, and it considers the patients as the experts. This is particular to the rare diseases studied because at the moment there's so little information about them. Patients contribute data to this data repository via the website, all about their experience of their diseases. Huge amounts of data that they're putting forward into this website. And what we've done with the team is to develop a dynamic consent module for patients so they can tailor their involvement in the study. You see the green ticks. If you come in as a patient, you can review this at any time through your profile, and you can change your mind at any stage, and that will then be reflected with what can be done with the research and with the data and the samples within research studies. The RUDY study is very particular because they're gathering so much information from the patient. We've also been developing software that just collects the consent decisions and just provides information to patients. This is much more sort of a module that could then be added to all sorts of different research projects. But crucially, we still are asking whether it works. RUDY has 1,800 patients signed up and using their website, and the feedback we've had from the RUDY study patients is they really like the dynamic consent bit because it makes the study less overwhelming. It means they can sign up to small bits when they first start and then open up their consent as the project continues. But we still haven't actually got hard data to suggest how dynamic consent affects the patient experience. So right now, that's what we're working on. We're working with a project called the Australian Genomics Health Alliance. So this is sort of like the Australian equivalent to Genomics England, where they're looking at how they can increase genomic sequencing within the clinical setting. So they're doing all the groundwork to set up sequencing for the future. And they're doing it at the moment through flagships for different diseases. So all of the work of the Alliance is organised through the tracking of these flagships. And we've recruited 2 flagships to trial dynamic consent. So we're actually running this as a trial within a trial. We're doing a comparison of traditional consent methods with a dynamic consent tool to see how it influences patient experience over time. 2 participating flagships, both a child study, which then involves the parents of the children, and then an adult study as well. They're randomized to whether or not they have a traditional consent or a dynamic consent approach. And then we're going to have a survey when they're first recruited, and then 6 months later that will then track whether their patient experience, participant experience of the research has changed as a result of the dynamic consent intervention. And what we want to look at as a part of this process is whether or not these various different elements have been influenced. So we'll be giving them a survey that's as part of that has questions added to the Australian genomics surveys. And then we'll also, for the dynamic consent users, be looking at different aspects of their use of the dynamic consent platform. For example, click-through rates, where they've spent time on different pages, which content they've accessed, how often they access the tool, all of those questions, which should give us a really nice idea of whether or not they're actually interested in this. This is the website that's been developed. So this has been developed specifically for the Australian Genomics Health Alliance. And this is just one of their consent pages. If a patient were to go in and change any of these decisions at any time, it would alert the team, and they would then be able to have a conversation to understand better why the patient has changed their mind and hopefully help them with more information about what the decision is. It's challenging setting up this trial within a trial. We don't want to mess with the study itself. We don't want any of the patients to have an adverse impact in terms of the genomics study, but we're also trying to fit with the timelines and the approach of the study itself, which does slightly influence our approach to evaluation. But we're still hoping this is going to give us some good feel for whether or not dynamic consent is worth pursuing. In terms of the future, we're very interested to see how this overlap between research and the clinic is actually going to become more and more blurry. In an ideal world, you'd have a single portal that was accessing all of your information, all of your sort of interactions with healthcare, and within that there would be a section that you could think about how your data is being used, not just in research, not just in a single project, but actually across the whole system, which would in fact include your clinical care as well. Potentially it would have an option to support findings, and potentially it would allow PPIE here is public, patient and public involvement and engagement. So it's sort of related to PAW, which we just heard about, in terms of how patients are interacting with research. And I don't know how, but it could look a little bit like a dashboard that you have on your laptops at the moment. Different information about your appointments, maybe access to your health results. You could pull in information from other news outlets or from other sources that would be of interest to you, potentially ask questions and actually access teams to actually interact face to face. Maybe you drag in data from other applications, from other areas of your life that is also relevant to your healthcare. Also, you'd be able to access information about the projects you were involved in, and then you'd have your consent preferences as well. This is the direction we would like to go in. How you actually set that up, particularly when health IT is no straightforward, integrated, single system. And we have theoretically in the UK have a single health system, but as anyone working in the UK will tell you, it's not even a single health system within one hospital. So how we actually get this set up and working is a challenge, but it's the direction we're hoping we'll move in. I just have some thanks to the various teams that we've been working with, and thank you very much for your attention. Yeah, sure. Does anyone have an immediate question? Just what?
Hi, thanks for the great talk. It's really interesting. So this is something I'm quite passionate about. And first question is do the patients also get a consent form for whether or not their data, website interactions are going to be monitored and things like that? Yeah, okay. And the second thing is I deal with autoimmune encephalitides. So we're looking at sort of autoantibody mediated diseases. And one of the issues that we have is obviously patients cannot always consent because they may not have capacity at that moment in time. But then, as you can imagine, their capacity is dynamic. So as they get treated, they then develop capacity. But if you're using a website interface like this, then how do you judge whether or not the patients regain capacity? Presumably that still needs to have a human face-to-face interaction.
So yes, and that is a really, really interesting area that we've talked about. Actually, we've talked about in with a team who have been looking at mental health and admission in emergency departments. And it's something we need to explore in more detail from a specific patient population. I'm fairly sure quite a lot of the work that we're doing is reasonably generalizable, but I still think in each different patient population there will be certain things that will need to be tailored. One of the questions we have is whether or not it's possible for it to support a family sort of decision making, or have a number of different people that are actually have different administrative sort of roles within it that could then potentially support that. At the moment, we haven't made more progress than just thinking about the fact that we need to think about it. But I think it is an important point. Thank you. I think we're going to